come up, and on the way up there, I found this little plastic thing. It looked like a brush. And I said, oh, this is a brush like you're brushing off home plate, so this is going to be my lucky charm of the day. Right. So I put it in my pocket, put on my batting gloves and get up there, and he throws a first pitch fastball at me, and it just, I was like, whoa, that's pretty fast. But
you watched it?
I watched it. I didn't swing. This is my first at-bat, and then next pitch he throws a curveball, and I hit it. And it feels good. And the wind is blowing out, so I won't say that it was all my power. But the wind was blowing out, and I hit it, and I start running as hard as I can to first base. And just as I'm running first base, I clipped my cleat on first base, and I fell down face first in the Texas dirt, just covered. And I'm just like, oh, I'm so disappointed.
You're gonna get thrown out.
I'm sitting here going, no, I didn't get a double. I thought I smacked that thing. Yeah. So I'm standing on first base, just so mad at myself. I'm brushing myself off, and the umpire goes, son, you gonna go all the way around or not?
Touch them all.
I was like, what? I didn't even see that it went out. Leave. No, heck no. I only hit one home run in my entire life at
That's
Newton.
Hilarious.
Over the last 2 years, I've started to implement something in my practice called a de-innervation, where everybody's heard of a joint replacement. When your joint wears out and you get osteoarthritis, as you know, of the knee and hip, the big surgery is a knee and hip replacement. They do very well, great orthopedic surgeries. In the hand, we have some challenging joints that are smaller, and there's other things you can do besides just go into a replacement. Mm-hmm. So one of them I've gotten into is a de-innervation, where I take actually the nerves that just go into the joint that send the signals back to the brain of pain, and I go in there and I de-innervate the joint. So I've started that over the last 2 years. So that's been a positive part of my practice that I've really expanded on.
The thing that interests me about you is that you work hard enough in spine surgery, you have a busy home life, and then you're telling me that on your weekends you're farming. Is this still true? And to what extent? It's interesting. How did you grew up that way, or?
Sure, I grew up on a hog, cattle, corn, and soybean farm in north central Iowa. I came very close to farming full time. My father said that he farmed so that I didn't have to, so I went to college partly to appease him. Yeah. I love the farm. It's a big part of what I think of when I'm not doing orthopedics. It's a great life and great relief.
Senior year in residency, I went to Uganda with another co-resident of mine, as well as one of my attending physicians, and that we operate every day, and that was orthopedic heavy. And so there was lots of people in the community, as well as people that would walk from miles around just for the opportunity to be seen.
The simplest terms, it's the part of your blood that helps with healing. So when you bruise, that's bleeding into the tissue. It's the platelets in the plasma, or the PRP part of the blood, that really helps that tissue heal. It tells the body, hey, come here, take care of this, but it also has some of the healing factors. And so that's the simplest way to think of it. It's not a magic wand, it's not something out of this world, but it really does have a concentrated amount of the stuff that really helps the body heal anyway. And we just isolate it using a centrifuge from your own blood, spin it down into a much higher concentration that is circulating in the blood, and then put it into place, typically with ultrasound, to get it right where it needs to be, to really help kind of tell the body, hey, come here, you had some unfinished.
Surgery for me is a combination of a little neurology, a little rheumatology, non-surgical orthopedics. It was started, basically got to become a bigger specialty after, I think, World War II. There was a lot of disabled veterans. They weren't sick, so they couldn't stay in the hospital, but they were disabled and they couldn't go home and take care of themselves. So that's how the specialty began. And from there, it kind of morphed into different things. Now there's outpatient physiatry, which is what I do, and that's more musculoskeletal medicine, more non-surgical orthopedics. I specialize more in back issues, so for me it's more non-surgical spine issues.
My fourth year, when you're doing senior rotations, I did sports first, and I was like, again. And I was talking to my now wife at the time, and I think she was girlfriend at the time, but she was going, I know what you're going to go into. I go, what do you mean? She goes, hand. You love it. And then I was like, no, she probably knows. She probably knows what I should be doing. And she was absolutely right. The thing I love about hand is that you're part orthopedic surgeon, you're part vascular surgeon, you're part neurosurgeon, you're part plastic surgeon.
My father-in-law used to be a hand surgeon. When he used to treat everybody, he would make them stand on the ground on a piece of paper, draw out their foot, and put it against their shoe, and they're like, no, not anymore, and it's true, So the bunion is a bump. Everybody, you get a bump around the toes. There's some people have soft tissue bursa, like you can get around other joints. Some people come in and they think they have a bunion. You take an X-ray and it's arthritis in there, more of a joint problem than a structure.
Fuse my ankle and do what?
Right.
Because they think that taking away that motion at the ankle, they're not going to be able to walk, they're not going to be able to move, that it's going to be extremely noticeable, things like that. And we can take videos of people walking, and you wouldn't be able to tell which ankle was fused in the majority of them.
Really?
Yeah, you still have a good range of motion through what we call Chopart joints, so in front of it. So you still actually do have some up-down motion. It's just through your foot. It's not as extensive as through the ankle.
So you spend a lot of time in clinic dispelling rumors of what it means and how functional they'll be. Can you run with an ankle fusion?
Absolutely.
You can. That may be an advantage.
So that's why people that are younger and more active or laborers are candidates for ankle fusion, not replacement, just because an ankle replacement in somebody that is 50 years old or 40 years old, 30 years old that had a really bad fracture at some point, if they get a total ankle at that point and it's only expected to be 8 to 12 years and they have 40 years of expected life left.
Had cubital tunnel myself. I woke up one morning in med school and my small finger was numb, and it was that way for about 8 months, and I haven't had surgery.
Wow.
I'm all better now, so success story.
Well, that might be why you went into upper extremity.
That's right.
I'm 5'11". My kids are 6'5" and 6'6", so I'm not sure where they got that from.
You said your daughter's a pro at shopping.
Yeah, my daughter's 5'2", and she is world-renowned shopper and very good at selling wedding
Has she honed
dresses.
her internet skills over last year with the pandemic?
I think she had that down well before the pandemic hit.
Doesn't need to try things out.
Right.
She can just kind of tell.
Right.
And then you can just send it back. I mean, it's just as easy, right?
Yeah.
It's just another avenue to purchase something else.
They're pretty tough, though, aren't they, farmers? Pretty tough.
Oh, man. They're the best. They won't complain about anything. Their arm will be falling off. I'm like, I'm doing all right.
Yeah, they're great.
Yeah, they're fun to work with.
We do this every day, multiple times a day. And I think, for patients, this might be their first surgery, second surgery. And I guess that's one of the biggest things I can kind of remember when I wanted to go into anesthesia was my uncle being like, surgery's a big deal for a lot of people. There's like one of the most stressful things that
it's a huge deal.
Maybe one of their most stressful times in their life. And like, you're going to be one of the last persons they see before they go off to sleep. And then, and you can do a lot to kind of, help with that fear, anxiety, just based on how you talk to them and what and how you interact with them right before that. So, again, but then once we're in there, then we're, they're taken care of, and then it's like the things that this is just what we do every day.
They're comfortable, and we just take care of
it. In treating this disease of obesity, using patient-first language to understand that it's not a person who's obese, it's a person who has obesity is an important starting point. And then talking about, we do both medical, non-surgical weight loss and surgical weight loss, and that sometimes helps it be less intimidating for people.
Yeah.
Most people don't understand the physiology behind the disease, and they've always been told this is your own fault. You got yourself into this, you need to get yourself out. And so we really have to reframe that conversation around your physiology doesn't work the way it should and the way it does in other people. And just like for somebody with asthma, we wouldn't tell them to go home and meditate and avoid all their triggers. We would give them medication to treat their life-threatening disease. And we need to look at this as a life-threatening disease that needs to be treated, and especially by experts in the field.
Like, I think, when schools don't include those people, so again, when I say those people, it can be parents, it can be a mentor, it can be whoever that recruit listens to. If you don't include those people, I think that's a big mistake. And so, one of the things that we really harp on is, being a relationship-based program and not necessarily a process-based program. So now I say that, and yes, we do have a certain way we like to do things. There's in our opinion, there's a right way and a wrong way to attack a certain day and to have a certain mentality. But if you don't have a relationship with that player and that player's families or that player's loved ones, they're not going to play hard for you. Right. They're not going to do everything you ask them to. And we understand, the coach's role is really a great role, because I can make your kid do something that maybe you can't. Like you tell your kid to make his bed and brush his teeth, you're going to get a lot of hums and ahs.
You ever have dads on the way up being like, just beat him up a little bit?
Some of them.
Yeah.
Those are becoming a little bit few and farther between.
Okay.
But at the end of the day, parents want you to treat their kids like you treat your own, and so that's always been our philosophy.
We were a new program, and so we had a lot of guys that came that wrestling was important to them. But those guys thought at the time that they could work hard within their sport, and that they would, if they worked hard in their sport, that was going to get them to where they wanted to be, even if these other areas, if they were kind of practicing letting themselves off the hook, and so they were okay with maybe average grades, or okay with a mediocre lifestyle, okay with a mediocre personal life or family life. And, for us, we started really preaching, hey, the more you focus on dominating in these areas, and the more you practice on just not letting yourself off the hook in these areas, the more that's going to carry over into your wrestling, because what you practice doing the majority of your day is who you are. And you can't assume that you're going to be great in this one area because you work hard in this one area, but these other 4 or 5 areas you practice being mediocre, you're mediocre. I mean, that's just who you are. And so the guys slowly started to buy into it, and we saw the results in the wrestling. But ultimately what they found out was this is really the main lesson that stuck with them the rest of their lives. And now that we've had wrestling for 13 years at Grandview, it's cool to see guys that they're out, they have careers, they're married, they have kids, and seeing them try to be the best in those areas. Something that we preached for a long time, that you hope that ultimately it's going to lead to you winning a championship, and it will give them the best shot at that. But it's a lot bigger than that, because winning a championship is not the most important thing in life. It's about who you are the rest of your life. And so that's really what it's been, and that's been the culture, and we preach it to every kid who visits campus, because we want that to be the number one reason guys decide to come to Grandview.
I'll take kind of a step back from that. I kind of look at this also both from an administration and that student athlete. Yes, I'm an adult. Yes, I'm an authoritative figure, but I'm not a parent. I'm not a coach. I'm not a teacher. So making sure that door is open, communication is fun, is easy. From a standpoint that I'm a resource for both, from a principal standpoint to I have daily interactions with our activities directors, which helps because a lot of times that's when maybe in passing in the halls that they're going to run into one of the lower level coaches and say, hey, when is Chris? I know it's football season. I know that takes priority. And I don't want to say that I don't care about that. I mean, yes, there's going to be priorities and you have to prioritize things, but ultimately it's the health care of everyone 9 through 12 that's going to be important. So it doesn't matter if they're the number 1 runner or the number 200th runner. Each one deserves.
It's really difficult to stop. You gotta get off the phone, turn the lights off, and have a very strict sleep
Why
schedule.
is that? Is that just biology, or has cell phone usage and gaming and stuff contribute to this?
It contributes a little bit. If you're somebody who never has a problem falling asleep or staying asleep, you can probably relatively safely use electronics at night. But for anybody who's trying to get up a lot earlier than they normally would, that light at nighttime is a really, really powerful stimulus to say, stay awake, it's still daytime, it'll push you even farther.
These are sometimes difficult surgeries, so like physically wise, right? So you have to do a lot of lifting and things like that.
Yeah, which is why I'm in such great shape. Yeah.
We'll see ACLs for, I'd say, kind of like 3 to 4 weeks before surgery. Typically just see them up until the time they have surgery. It's great because a lot of times those patients come in and they're pretty down and out that they're going to be in PT for a while, they're going to be out of their sport for a while. So building that rapport, building trust with them, explaining what to expect pre-op and post-op for those patients, I think they do a little bit better as well.
In terms of anxiety and things like that?
Yeah, getting them moving, getting that knee bending, getting them starting to get some strength back.
The culture that we live in makes it really difficult for young female athletes to find confidence in their actual needs, and I'll just go, specifically to, let's just say, endurance female athletes. What is the typical look of an endurance female athlete? And that's the problem. There is no typical look. There should not be a typical look, but that's not what we've been told for so long. And so I think social media plays a huge role into the challenge that young female athletes face. But I will say the silver lining of this is there is so much more conversation now about how to fuel your body and the benefit of having a monthly period, and there's so much more conversation. And I will say you gotta be looking for it. It's not gonna just fall on your plate on accident, but there are so many dietitians and coaches and trainers who are talking about this and becoming more comfortable with that conversation around fueling for athletes, specifically young female athletes.